and I would like to introduce everyone to Evie, who actually is a friend of mine from uni, and she's now a registered dietitian, and she's going to have a chat to us today about, I guess, dietetics, as well as how, I guess, medicine and dietetics can relate to each other. So welcome, Evie. Thanks for joining us.
Thanks, Lucy. Let me just put my share screen on. Let me know if this is working. Hopefully. Actually, does that show me as well or just the screen?
I can see the screen and then you kind of on a side little box.
Okay, perfect.
People see.
Okay, well, hi everyone, and thank you for coming today or watching later on YouTube. Before I begin, I'm quite a casual person and I prefer to be interactive. So happy to answer questions at any point. And if you want to just put them in the chat box, I will hopefully be able to see them, or maybe Lucy can let me know.
I'll monitor the chat box and I'll let you know.
Thank you. Yeah, and just to start off, just getting an idea of what type of students everyone is, if they're your medical or dietetic or anything else, because I wasn't too sure who I was tailoring this talk towards. So it is much more of a towards medical students and a little bit towards dietetic students at the end. Again, happy to answer any questions if I don't answer them in the talk. Okay, cool. So my name's Evie. It's pronounced like the Pokemon, and I'm an accredited practicing dietitian. I primarily work in outpatient settings, so that's like private practice. And I mainly work in eating disorders. My practice is called The Recovering Place. You can see a little logo in the background. And I'm also completing a PhD at the moment looking at what it is dietitians do in eating disorder treatment. So this is my passion area. I do get a little bit carried away, but I'm going to try not to do that today. Today, instead, hopefully I'll be able to explain a bit about dietitians. So kind of the contents, what the difference between a dietitian and a nutritionist is, because I know that comes up a lot, what exactly we do in different settings, how we work with doctors, and then a little bit about, had to sneak it in, what dietitians do in eating disorders, and just a little bit to spice it up, a bit about atypical anorexia, since it's an eating disorder thing that you might not learn so much about, as well as weight stigma. And then at the end, for the dietetic students, career pathways and a few tips. Okay, so let us start with what is a dietitian? Okay, so if anyone has any preconceptions or ideas, I welcome you to put them in the chat box. I'm always interested to know what people think straight off the bat when they haven't met one. But there are a few terms out there that it's important to know the difference between in a healthcare setting. So there's dietitian, nutritionist, accredited practicing dietitian, and accredited nutritionist. Confusing, I know. So what exactly is the difference? In Australia, the term nutritionist and dietitian really, they're not really regulated by the government. So doctor, you can't be a doctor unless you've got a medical degree or you're a chiropractor or a dentist. But dietitians, nutritionists, literally anyone off the street can call themselves that. People who do a 4-week online course can call themselves a nutritionist. Might see a lot of these people in health shops and gyms selling really expensive vitamins and allergy testing things. Yeah, those people. So to protect our profession, we developed accreditation. So accredited nutritionist and accredited practicing dietitians. In Australia, to become a nutritionist, an accredited nutritionist, you complete a 2 to 3 year degree around like health science, and then you would register with Nutritionist Australia. So it's not compulsory, but it does help to distinguish you a little bit. And then to practice as a dietitian, you complete a 4 to 5 year degree, and you can also register with Dietitians Australia, which is compulsory if you do want to work in like outpatient or private practice settings. But if you work in a hospital, you don't need to register. You just need to do the degree, obviously. So even with that, a lot of people ask, okay, cool, you have a different number of years of uni you go to and you've got a different title, but what really is the difference between accredited practicing dietitian and an accredited nutritionist? So the primary difference is that dietitians are trained to provide dietary counseling, medical nutrition therapy, and food service management, so like making diets for hospital, and can provide all of these services to sick people. So nutritionists are really valuable, and they have skills in like improving public health research and public health policy, as well as community settings where they can do things like general population optimal health stuff, but they're not able to prescribe diets in disease states. So they're, simply put, they're not able to tell sick people what it is to eat to get better. It's also important to note that all dietitians in Australia do hold qualification to call themselves nutritionists. It doesn't work the other way around. And only dietitians can work in hospital settings. So that's kind of the big thing. You might also notice that dietitian can be spelt with like a T or a C. In Australia, it's spelt with a T. So if you want to get on a good side, spell us right and don't call us nutritionists. Those are our two pet peeves. Okay, so now that we kind of know what the terms mean, what do we actually do? Like medical nutrition therapy or dietary counseling, like they're terms, but what does that actually mean? Well, I'm sure you've all hopefully learned a little bit about the pathology behind things like diabetes, cardiovascular disease, renal disease, all that stuff. But have you ever wondered, outside of medication, what do people do to lower their cholesterol or control their insulin resistance? And what do we do if an oncology patient who has trouble eating because they've lost their appetite or have mechanical troubles eating comes in? Like, what do we do? And who knows what to do? Or you have someone who needs formula to be fed through a PEG tube or an nasogastric tube. And how do I know what rate it needs to be at? And why does the rate even matter? Like all of these questions. Those are things you'd ask your friendly neighborhood dietitian. We're usually pretty friendly, hopefully. So in a hospital setting, it's pretty easy to spot the work of a dietitian, other than the fact that it's labeled with a computer. If you see anything like diabetic, low residue, low potassium, no added salt, high protein, high energy, these are all dietary prescriptions a dietitian has put in place. So dietitians in hospital will often consult medical teams to determine if a restricted diet is necessary, because unless absolutely medically necessary, such as like fluid or sodium restriction in someone who is doing hemodialysis, we don't like to limit the types of food people consume, especially in hospital settings where intake is already suboptimal and malnutrition is usually our biggest issue. So instances where you'd refer to an inpatient dietitian in hospital are this plethora of things on the PowerPoint slide. A few of the big ones are swallowing difficulties. So you would also refer to a speech pathologist to just check their swallow, make sure they're not going to aspirate before you refer to a dietitian. Immediate referral if there's an MST that's greater than or equal to than 2. It's part of the Waterloo assessment on admission, so it should be the form that the nurses usually tick off. If you're planning on changing patient's diet code, dietitian, just to make sure that nothing, like if you change from a normal diet to, I don't know, something that's like a fluid restricted one, that they're not also having no added salt or no potassium, just to make sure. Refeeding risk is a big one. So that's when someone is malnourished and their electrolyte, if you feed them too quickly, their electrolytes will go out of whack and they deteriorate very quickly because pretty much everything stops working. So that's a dietitian thing. But all of these things, you would just refer to a dietitian, we'd come and see them, and then we'd be like, hey, this is what we think, and consult with the doctors as well. A quick note though, I was speaking to a few of my hospital dietitian friends, and one of the most common referrals that dietitians get in hospital is for low albumin or low pre-albumin levels. So I'm not sure if anyone knows why this might not be an appropriate referral. So little background, albumin and pre-albumin, they're visceral proteins, and traditionally we kind of considered them as useful biochemical markers for nutrition assessment, like essentially saying, oh, they don't have enough protein or muscle mass, and that's why they've got low pre-albumin or albumin. But recent studies have shown that there are many other factors that affect these measures, especially inflammation. And guess what? They're in hospital, probably got inflammation. So a lot of the times it's not, well, most of the time it's not a good proxy measure at all for total body protein or muscle mass. So it's not a good nutrition marker. If you have someone with low albumin or pre-albumin, just ask, do they have a history of unintentional weight loss, being underweight, poor oral intake, regardless of weight? Please then refer to a dietitian. Or if you're unsure, that's totally fine as well. But if they're a totally happy, healthy human being who's come in and accidentally broken their leg and just come in for that, and their albumin's high, don't refer them to a dietitian.
I've definitely seen that being done. Just a reflex, low albumin. Oh, I guess we'll refer to the dietitian.
Dietitian, yeah. Like, let's be real. Everyone's in hospital. Everyone's got inflammation. Like, chances are it's gonna be there. Yeah. So just take a little bit step further, just to consider if it's necessary, because it means that we're taking time away from seeing the other issues to come and see this person. Okay, so outpatient or private practice settings. In these settings, this is more like working with GPs, or if you're referring from hospital to go see a community or outpatient dietitian, it does work a little bit differently, because anyone in the community can go see a dietitian without a referral. But if they get things like a team care arrangement or a GP management plan, some of their visits can be subsidized. So with these plans, patients have 5 visits total to see different allied healths to help manage their chronic condition. And they might be, so chronic conditions are things like diabetes, dyslipidemia, CVD, PCOS, IBS, all of this other stuff. Eating disorders is one of them as well. It's a little bit different for eating disorders because the government actually introduced the eating disorders care plan. So that means that people receive 20 subsidized visits to a dietitian and up to 40 to see a psychologist every year. Good stuff, I guess. But in general, even if someone doesn't have a care plan, they can still go and see a dietitian, and we'll also do things like disordered eating patterns, chronic dieting, transitioning and managing vegetarian and vegan diets, so like iron levels, B12 levels, pediatric feeding, and all this other stuff that's there that I won't bore you with by reading through. So in all of these cases, coordination of care between medical practitioners and dietitians is really imperative. So there are things that we can't do, and there are things that GPs can't do or specialists can't do. So the GP or specialist is still responsible for medical monitoring. So that's things like running your blood tests and conducting the physical examinations and writing specialist referrals. In many cases, dietitians do require additional blood tests to be run. Like if we have a diabetic patient, every 3 months we would ask for a HbA1c just to see how their dietary changes are going. Or in eating disorders, sometimes we would run weekly tests just to make sure their electrolytes are on point and they're not going to go into like total organ failure. So these are things we're not able to order them directly. We will usually let them know, but it's the GP's job to do that. Similarly though, works the other way. GP can defer to dietitian to see if any medication needs to be changed based on dietary changes, such as like, again, diabetes. If a patient is or doing everything they can with diet and it's not changing, it might just be a genetic thing and they're not able to do anything more. They might just have to increase their dosage of metformin, whatever medication they're on. So hopefully you can see why it's so important for effective communication to occur in all these settings, because if one person isn't telling the other person what's happening or what they're doing, then patient isn't getting the best outcome. Okay, so one little thing that I did want to touch on, and I know it feels obvious, but if you're a medical student planning to be a doctor, try to please remember to stay in your scope of practice. So a lot of times in outpatient and inpatient settings, doctors can sometimes accidentally overstep, especially when it comes to nutrition. And look, I do not blame you or them. It's really easy to do, okay? We all eat, we all read articles on the internet, we all have opinions about food and what's healthy and what a good diet is. But it's important to remember that whilst it's fine for you to hold these thoughts and discuss with your friends outside of practice, it's not okay in a healthcare environment. I'm not sure about your course, but every doctor I've spoken to, including my partner, has told me they've received maybe one lecture on human nutrition. We spent upwards of 4 years literally learning this one thing. So the same way you wouldn't prescribe exercises for joint rehab, or where we wouldn't tell a patient to change their medication, doctors aren't trained to provide nutrition advice, so please just do refer on. Cool. Now that I've got that out of the way, just repping all of my dietitians out there.
I guess it's good to know, and because sometimes we feel like, oh, do people think we're passing the buck when we're just like, oh, go talk to your dietitian about this.
Yeah.
Don't talk to me. But I think it's good to know that you guys actually like prefer to start from, I guess, a blank slate without them being maybe misinformed.
Yeah, no, definitely. Like the number of times I've had people come in for diabetes and they're like, oh yeah, my GP just told me not to eat carbs. And I was like, oh, that's a terrible idea. Please do not do that. So yeah, no, like we really appreciate when just when people recognize where their area of expertise is and not gonna judge at all.
That's great.
Okay, so just doing a little bit, because I couldn't help myself, what dietitians do in eating disorder treatment, because it is quite different. And if you do go into psychiatry, then this would be something that you work with, or if you get a term in psychiatry, this might be something you see. As an eating disorder dietitian, many people think our job is simply to prescribe a diet plan for our clients or patients, depending on which term you prefer, and then hand it over to the psychologist or psychiatrist. And originally, this might have been the intent of the job description, but in reality, it's not what happens. We're often the ones who coordinate care, so we're the ones who contact all the healthcare team and make sure that we're all on the same page. In outpatient, we're often the ones who know the most about which biochemical markers and tests need to be run, just because it's our area of expertise and we focus on it so much. We also provide nutritional counseling and try to increase our clients' motivation to change. So to give you a bit of perspective, a GP's appointment is usually around 15 minutes. Typically, an initial assessment with an eating disorders dietitian is an hour. And review sessions are about 45 minutes long, at least. In that time, we're trying to build rapport and essentially hope that by the end of the session, the client's going to be willing to jump off a cliff. Because that's what eating anything feels like to someone who has an eating disorder, jumping off a cliff. I'm not exaggerating. I've literally had someone tell me, like, this feels like you're telling me to jump off a cliff and I can't do it. So hopefully you can appreciate why saying like, hey, here's a meal plan, cool beans, just follow it, you'll be mint, isn't going to work. So it isn't the easiest job, definitely not something we're prepared to come out of uni and do, like similar to, like we're given I think 2 lectures on this. So it is a specialization. So kind of like a specialization once you become a doctor. To work with eating disorders, we do a lot of continued practicing development, continuing professional development, CPD, and we learn a lot of therapeutic treatment modalities. So our lines do blur a little bit between what we do and what a psychologist does. And that's what my PhD is on, funnily enough. So whilst the job is incredibly emotionally draining, it's also incredibly rewarding and a privilege to be able to walk people through some of the toughest parts of their life. I am trying to not go on much more about eating disorder work, but I will end this part with a few myths about dieting and a little bit of a history lesson, if that's okay. I'm not sure if any of you have heard of the Minnesota Starvation Study that was conducted in 1944. It was conducted by Ansel Keys, a professor of physiology and consultant to the War Department, who sought to explore how individuals would be affected physiologically, always have trouble with that word, and psychologically if a limited diet was provided, and then how to refeed them essentially. So essentially they were starved and then refed, and we would not be able to get ethics for this nowadays at all. It was torture. The experiment recruited 36 young, healthy men, so I'm just gonna healthy, who were essentially put on an extreme diet, and it resulted in them becoming incredibly preoccupied with food. They had concentration issues. Their interest in food expanded, so they all started reading cookbooks, collecting recipes. During meal times, they would be really possessive of their food and guard it really defensively and use really small eating utensils to be able to eat it slowly. Like if they didn't have it, they'd get aggravated, and they'd toy with their food. In the rehab phase, even more things developed. So they would eat several meals in one setting or have headaches and gastrointestinal upset despite eating a normal diet, or they would binge and purge in the refeeding period as well, even after 5 months of refeeding. So these behaviors continued on past 5 months, and they developed body image concerns as well. People who were extroverted became isolated, and they described themselves as socially inadequate, and they developed new anxiety and depressive symptoms, hysteria, hypochondrian, like they became hypochondriacs, and they were more sensitive and argumentative. So these were all things that happened to young, healthy men because they were put on an extreme diet, which is what we would, I guess, say anorexia nervosa is. So I'm sure it's not surprising that these are the signs and symptoms for eating disorders, especially anorexia nervosa. But what I'd really like to point out here is that starvation can occur in people of any body size or shape, and it's relative to the individual's needs. So weight suppression is comparative to a percentage of body weight a person loses, and even a 5% loss in the presence of other symptoms is clinically significant. So other symptoms are like preoccupation with food, or binge eating, or purging, or food restriction thoughts, or body concerns. So all of these types of things. And what we call this is atypical anorexia, which is hilarious because it appears 3 times more in the population than typical anorexia. So it's just anorexia that occurs in people who aren't at a low weight, essentially. So in the medical field, we do have a bit of a preoccupation with the fact that disordered eating patterns, starvation, restriction, these are all symptoms described in the Minnesota diet, but we say they only occur in people who have a normal or lower BMI. But it also occurs in people in larger bodies or much larger bodies. So I might take this opportunity to delve a little bit into the idea of weight stigma, which might be something that it's not usually a medical thing. So just dipping the toes in a little bit, and how it relates to dieting and its harms. So weight stigma can be defined as discrimination or stereotyping based on a person's weight, and it increases body dissatisfaction and is a leading risk factor in the development of eating disorders. So because of weight stigma, people in larger bodies are often congratulated, even though they have the same disordered eating behaviors as those with more stereotypical anorexia nervosa. So up to 52% of individuals classified as overweight or obese who engage in any form of weight loss program meet the criteria for binge eating disorder. And furthermore, new systematic review showed that whilst weight loss is possible, it's not stable or sustainable, with the majority of individuals regaining that lost weight and sometimes often more within 4 years. So now imagine how often someone in a larger body might be encouraged to go on a diet, which is statistically doomed to fail, and how often those same people might be congratulated for severely restricting their intake and over-exercising simply because they've lost weight and that's what we've decided is necessary for them. I'm also going to throw out there that there's often this magic number of 1,200 calories that floats around. I'm just going to let you know that that is the energy requirement for a 3-year-old child, okay? Not a full-grown adult. I have seen GPs recommend this to people and please don't do that, okay? I love GPs, do not get me wrong. My sister's a GP, just some other ones. It's ridiculous to expect an adult to be consuming that. And so the little message I'd like to leave with you is that instead of focusing on weight, it might be a bit more feasible to address behaviors as a health strategy instead. And what this might look like is encouraging gentle and sustainable changes to eating habits or increasing physical activity in ways that are enjoyable to the individual rather than a punishment or a chore. So it's something to think about. If you are interested in learning more, I'd start with this RACGP article, which is geared towards GPs. And then if you'd still like to learn more, I've got a few journal articles, a website, and a few books there as well, just to get you started. All right, so on to the last section. I'm not sure if I've got any dietetic students here. If I do, hi, I hope you haven't scared you away. Hope you still want to be a dietitian. Yeah, so one of the things, I've only got 2 slides for you, but my number one tip for dietetic students is to really look at the different career pathways you have open to you. So I know I've spoken a lot about clinical and private practice work. So for the doctors out there or medical students in our field, clinical usually means hospital-based and private practice usually means outpatient-based. But there is so much more out there that you can try. And if any of these things interest you, food industry, government, research, communities, all of this stuff, if any of them interest you, reach out to someone who's in that field and ask them if you can have a coffee, because I've never met a dietitian who wasn't happy to have a sit down chat with a student. I've never met one. We often feel like we're boxed into 1 or 2 pathways when in reality there's hundreds of ways that you can use the skills you develop as a dietitian. So make sure you keep your eyes open. The other thing is study and CV tips. This is something that as a ex-med student, it was strange to me to not do this, but a lot of my fellow dietetic student friends back in the day hated their chemistry, biochem, and pathology. Dietetics is a science degree, okay? If you came in thinking that it's something like, oh, fad diets, it's not. Please learn these things. They are so valuable. And they're going to challenge you. So chemistry, many of you may never have done chemistry, and it's be like, why does this relate to nutrition? It's going to teach you the chemical processes that drive nutrition uptake and how we use those nutrients. It's also going to inform your ability to understand why you're asking your clients and patients to do the things that you're asking them to do. And it's going to be challenging and make you become a better critical thinker. So don't just sit and think, okay, I'm just going to fudge this subject. Like chemistry especially is one of the ones that gets put in the bin. Just do it. I know it's hard. I know it's beyond high school chemistry, but you can do it, okay? The other thing is attend lectures and make notes, and then notes of your notes, because those are the things that you're going to be studying off. Form study groups when it comes close to exams. So sitting with each other just to do some study together is a really great motivation, or explaining concepts to each other is the best way to learn. So being a teacher is the best form of learning, I've heard and experienced. And YouTube is your best friend. Same with medical students. I'm sure if you've watched Lucy's talk, YouTube is your best friend. If you don't understand something, go on YouTube. Someone has explained it there.
Yep.
Okay, and for your CV, if you don't have experience, get some, okay? When you're out there practicing as a dietitian, our number one skill is our communication. If you don't have strong communication skills, that's okay. Now's the time to develop them. Because if you're sitting in a room with a client, you're going to be there for a minimum of about 20, 30 minutes. Okay? You have to hold a conversation for that long. Now is the time to learn how to be a good communicator. So that doesn't mean that you have to do anything dietetics related, even if it's part-time jobs, uni volunteering, that's all okay. And just get out there. In terms of volunteering though, if you want to get ahead and get a better chance of being employed sooner, look out for any nutrition teaching opportunities in high schools or primary schools, anything that's like a food bank, cooking meals for people without homes, or taking a job as a dietitian or nutrition assistant in hospital. These are all things that are going to separate your resume from the rest of the people. So everyone's going to have clinical experience. Everyone's going to have uni experience. You have to do something more. But a few of the less obvious things to leave you with, please make some friends, okay? They are the people you're going to fail together with, and that's the best part, because you're all going to not know what's happening, and it's a whole lot easier to not know what's happening with other people. They're also going to be your colleagues and the people that you ask questions to. So make friends, take care of your mental and physical health. Might be the first time you've moved out, and that might be hard. You might not get a job for a while, and that's okay. Sometimes it takes over a year or two to get any job, let alone where you want to be. And last of all, compare yourself to yourself. So everyone else's journey is going to be different, and that applies to medical students as well. Sometimes you'll feel like people are doing better than you, or they've got their insert expletive word. They've got everything together. No one has everything together, okay? So just compare yourself to yourself and you'll be fine. Okay, so that is my talk. Does anyone have any questions for me, or?
Yeah, feel free to pop it in chat or unmute your mic and ask a question. There's no such thing as silly questions.
There really isn't.
Hello. So, sorry, can you hear me? I'm just not sure.
Yes.
Yeah.
Okay, right. Yeah, so because it wasn't lighting, it usually lights up. Just as a background, I'm a medical student. For like all the other medical students on the talk today, I know there's sort of like just anecdotally this stereotype that like when doctors make referrals to allied health, they tend to be very like, you know, short, like not necessarily informative referrals, like, you know, just like, oh, referral to allied health or referral to dietitian. So I guess from a dietitian's perspective, like what kind of information should we be giving to you about the patient when we refer them to you that would be like the most helpful or the most important for you to know?
Yeah, that's actually a really great question. And I have seen those referrals before. So
Yeah, so like, yeah, how can we make like a good referral?
Just if you think about it, I think it gets lost in the hospital a bit, but the people you're working with are just people, right? If you were explaining this to another doctor, what would you say? You wouldn't say referral to doctor, right? You wouldn't say referral to, like if someone had a broken bone, you wouldn't just be like, all right, please someone come see them for their broken bone and not give any indication of that it's a broken bone, right? So if someone comes in with, just let us know, literally just let us know why you want us to review them. If it's a lot biochemical marker that's gone off, just say abnormal biochemical markers, brackets, what it is. Or if it's a disease state, like they're on hemodialysis or they've got chronic kidney disease, dietitian referral, and then chronic kidney disease, dietary management, question mark. So literally just something to let us know what's going on and why you've referred us is really helpful. Yeah.
Are there any like markers that you would find helpful? Like, for example, you know, like if I were to refer a chest pain to a cardiology department, they would want to know the troponin. Like if I refer, I guess, like you said, there's some specific cases where like, you know, this is a biochemical marker problem, but like, I guess, do you want to know their diet, like what their usual eating habits are? Do you want to know their weight, like things like that? Or is it kind of more that like a general picture of why they're unwell or why they need a review?
A general picture is usually what we're looking for. Like all that other information, once we come in, we will ask anyway. So it's like, for example, like low weight or something was what you concerned you. You can say like weight decrease question mark. And then we would ask, what's your weight's been like, all of that other stuff. So just a general idea is great. Or if there's anything specific, then put it in. But just whatever you're picking up and wanting to refer us for. Yeah. Just, yeah, medics, don't just write dietitian review. Or what?
Yes. just review the patient.
Just review.
Yeah. No, definitely. Thanks, Cherie. Does that answer your question?
Yeah.
Awesome.
Yeah, I've definitely seen that in hospitals too. Just like, yeah, dietitian review and then nothing else.
Or physio review.
Yeah, and then it's like the doctor gets paged like by the dietitian and they're like, oh, hello, like, so like, why did you want me to see this patient? And it just like takes like more time, you know what I mean?
Yeah, just one line's fine.
Yeah. Oh, that's good to hear. Sometimes I wonder if mine is like too brief. You know, sometimes I'm like, oh, refeeding syndrome. Please help.
No, that's fine. Like if you want to give us more, that's fine, but just something.
Something, an indication.
Yeah.
Yeah.
Are there any, I guess, reliable sort of dietitian approved like resources that like other health professionals like doctors, I guess, can read or can look into to better educate themselves, I guess, on sort of things surrounding dietitian like work and, you know, like what is actual correct information? Because obviously, like you said, there's a lot of misinformation and there's a lot of I guess very anecdotal almost, not necessarily fully evidence-based like dietary advice floating around out there, not just, you know, for the layperson, but I suppose like even amongst like the medical community, you know, like things about keto diets or like intermittent fasting, or like you hear all these words being thrown around, like is there sort of like what would you say is like a reliable place that we could go to find out more information about these sorts of things?
I'm going to give you my tongue-in-cheek answer first. Your dietitian. But in reality, really just like if you've done medicine, you have all the skills to hopefully do like substantial research and be able to recognize when journal articles are good or not, and then be able to look at systematic reviews and meta-synthesis. If you really are interested, then that's probably your best port of call. And at the same time, like I do get asked that by doctors a lot, like, then how do I know? And the answer is, well, if you're finding out for yourself, that's fine. But if you're finding out for a patient, it probably means you need to refer on. So it's not just those articles as well, it's understanding what the nutritional process behind those diets is and how they're affecting bodily function that might not be necessarily covered in an article. So really the answer there is refer on. If you're looking for yourself though, have an article, like look up some articles, maybe go see a dietitian. But yeah, like journal articles and being able to trawl through that is probably your best bet, or something written by a dietitian, like if you're looking for opinion piece type things, then something written by a dietitian. Yeah. Thanks for asking the question, Shuri.
Does anyone else have any questions, thoughts?
I might leave this slide up as well. Like, thank you for listening if no one else had any questions, but these are my contact details, just if you do have anything. Yeah.
Well then, I think we'll wrap it up then if no one else is speaking up. Thank you again so much, Evie, for giving this talk. I definitely find it very informative, and you know, like a lot of the times we don't know, and so we just did what everyone else says or do, but it's always good to kind of hear it kind of firsthand from the dietitian perspective about what's helpful in the medical, I guess, in the hospital world. And I also hope if we did have any dietetics students that they found your advice helpful at the end as well. So thank you again. And I think we might just end this talk here then. And hopefully I'll see you all sometime soon. All right.
Lucy.
Bye, everyone.